Good evening, everyone. My name is Stacy Jean-Claude. I'm the Outreach Program Manager at Massachusetts General Hospital Transplant Center. And tonight we are hosting a webinar to provide updates in kidney transplantation. We have a couple of our experts here today, Dr. Elias, Dr. Cotton, as well as Dr. Riella, and I'll let them introduce themselves. Dr. Riella?
Hi, I'm Leo Riella. I'm the Medical Director of the Kidney Transplant Program at Mass General. Welcome, everyone.
And Dr. Elias?
Good evening, everyone. I'm Nahil Elias. I'm a transplant surgeon and the Surgical Director of the Kidney Transplant Program at MGH. Welcome to all of you, and thank you for joining us.
Last but not least, Dr. Cotton.
I'm Camille Cotton. I'm the Clinical Director of Transplant Infectious Disease at Mass General, and I've had the good fortune of meeting many of you over the years. We're very happy to be with you today.
Great. And this is our agenda today. Dr. Cotton, if you want to get us started with the vaccinations and treatments for the immunocompromised.
Sure. We have a great lineup. Next slide, please. So there have been a lot of questions about COVID vaccines. Just to summarize, at this point, it's recommended that all transplant patients have had 5 vaccines. So that means 3 doses of the mRNA vaccines as part of the primary series, followed by a booster 3 months later, and then another dose 4 months later. So hopefully most people are up to 5 doses of vaccine at this point. I will say that hopefully in either September or October, we will have a new vaccine that we are hoping is approved by the FDA and recommended by the CDC. And that will be a 2-part, it'll be 1 shot, but inside that shot, it will cover both the old COVID strain and then the new Omicron strain. So that should be really exciting and should provide even better immunity. And we've seen some good safety data. And so that's how we will probably launch into the fall. Next slide. In addition to vaccines, it is recommended that transplant patients get this monoclonal antibody called Evusheld in order to protect against COVID-19. And we know that transplant patients have less of a strong immune response to vaccination. So we recommend that they get vaccine plus Evusheld. And Evusheld is now recommended every 6 months. So if you had a dose last February, you're actually due for another dose soon. It does cover BA.5. It's a little less effective against BA.5, but we're still seeing excellent clinical protection. And the only rule of thumb is that you shouldn't get this for 2 weeks after you get a vaccine. So it's works really well. We think that this has really changed things. And on the next slide, we actually have the report by Dr. Riella's group that this long name, tixagevimab, silgevimab, is Evusheld, and it's they published that there is a lower risk of COVID infection and no safety concerns in transplant patients. So this is really reassuring. And I will say this is our own data, but this paper has gone far and wide internationally, and people have really been thankful for this data. So kudos to Dr. Riella and his team. So what else to do in addition to getting vaccines and Evusheld? Well, you should encourage your friends and family to be vaccinated. Whenever possible, make sure that you get vaccinated before transplant, because vaccines work a lot better before transplant. So that's when they're the most effective. Do be cautious about exposures. Right now it's summertime. People are doing a lot of outdoors activities, so that's great. There are very high disease rates out there. So do be careful. And whenever you're indoors, wear a mask whenever you're around other people. And again, we look forward to having new vaccines this fall. Next slide. What about illness? So if you do develop any symptoms of COVID-19, fever, respiratory symptoms, headache, maybe you feel like you have allergies, do a rapid test at home. And if that's positive, call Transplant Clinic and your primary care doctor. And if the rapid test is negative, but you think you might have COVID, go ahead and get a PCR, because that is a much more sensitive test. And then for treatment, for transplant patients, we usually recommend monoclonal antibody because the antiviral medication called Paxlovid has a lot of drug interactions with the anti-rejection medications. So we're usually recommending monoclonal antibody, and we've seen really good success with the monoclonal antibody treatment. That's for outpatients. I do want to highlight that we have a new national effort in the transplant world underway to encourage better vaccination against hepatitis B. Hepatitis B can be transmitted at dialysis, during transplant, from blood transfusions, sexual contact, or mother to child in pregnancy. And we are trying to vaccinate all Americans against hepatitis B and really do away with this disease. And there's a special effort to vaccinate everyone prior to transplant whenever possible. This should be readily available through your kidney specialist or your dialysis unit. And we are working on that with the transplant coordinators as well. These vaccines work less well, similar to other vaccines after transplant. So really important to focus on the high-risk population whenever possible. Next slide, please. Regarding monkeypox, so what we've seen with monkeypox is that about 99% have occurred in men. 94% of them have had recent male-to-male sexual or close intimate contact, and racial and ethnic minority groups appear to be disproportionately affected. About 40% are, varies across 40 to 60% are HIV positive. And we know that, as you can see in the graph on the right, we've seen a lot more monkeypox in the past couple of months. And basically anyone who has a rash that could be monkeypox should be tested and to see if they do have monkeypox. Next slide. Things to look for if you're concerned are a rash that can look like pimples or blisters and can be painful or itchy. People can have fevers, chills, swollen lymph nodes, exhaustion, muscle aches and backache, headache, and respiratory symptoms. And this is copied from the CDC website, so you can either scan that code on the screen with your phone, or you can look at the CDC website. And I would always encourage you to use the CDC website whenever you have questions about COVID or monkeypox or anything infectious disease, because they really do a good state-of-the-art job with those topics. Next slide, please. So what about monkeypox vaccine and treatment? Well, there are two vaccines available. One is the ACAM2000, and that's a live viral vaccine that should not be used in transplant patients. It's actually not being offered right now. We are giving a lot of monkeypox vaccine in my infectious disease clinic, but we are not giving ACAM2000. And then the Jynneos vaccine is replication deficient. This is similar to the J&J vaccine for COVID-19, and this one is okay for transplant patients. We would predict that it's less effective in transplant patients, similar to other vaccines, although we don't really have that information yet. So if you do have a need to get vaccine, you should go with the Jynneos, which is what's available now. Now, who should be vaccinated? So this is currently recommended for people who had known monkeypox contact or who've had at least 2 sexual partners in the past 2 weeks. And it's not currently recommended or available for people without risk because we have very short supply. So it's really just being used for high risk situations. TPOXX or tecovirimat treatment is available, and this should be easy to use in transplant patients, no major drug interactions. And it would be good to let transplant clinic know, as we might consider, depending on your state of health, we might alter your immune suppression. So if you do have monkeypox, definitely let clinic know. And the overall impact of infection on transplant patients is not yet known. Next slide, please. I'm proud to say that this is a publication that's just coming out today. It's barely hit the internet, and this is on monkeypox and transplant recipients, no breaks between outbreaks. And in it, we discuss various vaccines and various treatment options that are available. And this is a nice collaboration between the current transplant nephrology fellow and myself that shows how we are always so collaborative between different specialists in the transplant unit in Mass General. Next slide, please. Great. And now we'll go on to the next topic, which is measuring kidney function.
Thank you so much, Dr. Cotton. And I wanted to just emphasize that, having Dr. Cotton on our team is so crucial, not only because she's an amazing clinician, but also she leads and she's part of the CDC advisory committee that actually defines, all these new policies that are coming and keep changing with all the waves of COVID and monkeypox and so forth. So she's on the advisory committee of the immunocompromised patients, our transplanted patients. So we always have a direct connection to what's coming down the line. And of course, we're even more thankful to all your excellent work with our patients on an individual basis. Thank you, Camille, again.
Thank you.
So we're going to shift gears a little bit and talk about kidney disease and how to measure kidney function. So we all know that, unfortunately, kidney disease tends to be a silent disease in the sense that you can have kidney problems and actually not know until it's really advanced. And one of the ways that we identify early kidney disease is through the measurement of creatinine levels in the blood. So this is a blood test that's done, and then we use a calculator in order to estimate what we call GFR, or glomerular filtration rate. This tells us about your renal function or kidney function. And this is just an illustration of, all the ranges. And of course, in transplant is a little bit different because we only have one kidney. But as your kidney progresses, your GFR goes lower. And once you get close to 10 to 15, this is when, unfortunately, you have kidney failure and you may think about other options of treatment in order to stay well and feel well. In addition to doing a blood test, we also measure protein in the urine, either in the form of albumin or total protein. And why is this important? Because the kidney filter is very tight and usually does not allow any protein to appear in the urine. So if we are monitoring someone's kidney function and we start seeing protein leaking into the urine, that's usually a sign that there's something damaging the kidney and we need to go after and try to find out what's going on. So next slide. So if we think about our patients, and if you're being transplanted or if you're waiting a kidney transplant, most of our patients get referred to be seen by our transplant team where their kidney function or GFR gets below 25. And why is that? It's because we want to try to get them through the process early so that we are prepared once their GFR gets close to 10 to 15, when the majority of our patients would benefit from a kidney transplant. Next slide. So there are a couple of caveats about creatinine that I think it's really important for us to kind of highlight. So number one, if we just look at our total population, there are certain patients that would have lower creatinines than other individuals. And that's not necessarily related to their degree of kidney function. So a few things that sometimes lead to a lower creatinine in patients is if you're older and you lose a lot of your muscle mass, if you don't eat any protein, so you do mostly a vegetarian diet, or if something happened with your health and you lost a lot of weight and you're frail, or if you have liver disease. So all these things can bring down your creatinine levels. And that does not necessarily mean that your kidney function is normal. So, but this is something we have to take into account. Next. And there are certain things that actually can increase your creatinine levels. So if you gain a lot of muscle because of exercise, if you eat a lot of high protein diets, or if you take protein supplements, or even some drugs may affect how the kidney kind of handles creatinine and may artificially raise your creatinine without actually affecting your kidney function. So this is important as we're kind of monitoring our patients and we're thinking if we see changes in creatinine to better understand if there's any explanation for that other than a change in kidney function. Next. So we use this calculation in order to estimate our kidney function, or GFR. And this is one of the calculators that's most commonly used. It's called CKD-EPI. And it takes a few different things in addition to the creatinine level in order to give us a number. It takes into account the sex and the age of the patient. And it also included in the past the race. And this was added on because it was found out that African Americans in general had a higher muscle mass and tended to have higher creatinine levels, and they tried to do that correction in the calculation. However, we do realize at this time that there are a lot of limitations about including race as a component of any equation in medicine, just because it can promote racial prejudice, and also because, you know, race is not a homogeneous group of patients. They're like very heterogeneous. There are a lot of diversity there. So there has been a movement to remove race completely from the equations, and this has been already done in our center and many other centers in the country. So let me show you here the impact that can have in a patient. So this is a patient that came for an evaluation for us, and he's of Black race here. And what ended up happening is that if you use an equation that includes the race in the calculation, it shows that he has a GFR of 23, versus if you use the same patient, but you do not include the race, for example, it gives you a GFR of 19. And what's the impact of those 4 mLs per minute difference here? The impact is that the patient that has a 19 can be listed on the waiting list in order to accumulate time, while the one that has 23 cannot. So a GFR of 20 or below allow us to place a patient in the waiting list so they can start accumulating time for potentially getting a kidney transplant in the long term. So moving forward, we have removed completely the race from our equations, and we're just basing our calculation on age, sex, and the creatinine levels. But as I showed you, you know, creatinine is not a perfect test. There are actually no perfect tests in medicine, but there are certain limitations. And sometimes we can get confused and in trying to explore if this change in creatinine is really coming from a change in kidney function or not. And there has been a lot of work done in another blood test called cystatin C. So why is this cystatin C an interesting blood test for us to consider complementary to what we do with creatinine? Number one, it's not dependent on muscle mass. So it's overall, it's much less influenced by age, gender, or muscle mass overall. It's released by a number of different cells in the body, and then it kind of filters through the kidney and so forth. And then as a blood test, it can actually be incorporated in order for us to measure the kidney function. Like any test, next, there are certain limitations in the sense that there are other things, for example, you know, inflammation, if you use high doses of steroids, that can potentially affect the cystatin C level. So cystatin C is not a perfect test, but how we see it is that it can be an important complementary test in the monitoring of our patients, either before transplantation or after transplantation. So at Mass General now, all our kidney transplant recipients post-transplantation, we have both a creatinine and a cystatin C kind of measure. And we use both in combination in order for us to monitor this kidney function and decide if any other intervention is needed whenever there are certain changes in those levels. Next. So overall, what I wanted to get out of this is that we estimate kidney function using a calculator that takes into account the blood creatinine. Blood creatinine levels are still an amazing test for us to monitor, but unfortunately, there are certain conditions that may change the creatinine levels. So we have incorporated cystatin C as a complementary test in order for us to better predict changes in kidney function going forward. And this is important because our patients will start seeing their blood work and start seeing the cystatin C being reported. And we, of course, will have more dialogues on a subsequent time and tell about some of the discordance and how we do interpret that. But this is a really kind of important new change that we have implemented in the clinical care of our patients in order to better monitor their kidney function post-transplantation. Next slide. Thank you. I'll pass it on to Dr. Elias, who will talk to us about addressing some of the equity in kidney transplantation. Thank you.
Thank you, Leo. Thank you, Camille, for a great presentation. We want to shift gears a little bit and talk a little bit about our equity in the kidney transplant work that we've been doing at MGH. As a reference point and to let you all know, National Minority Donor Awareness Month is this month, and this is a campaign going on across the country with all the, you know, the Donate Life, the community that really works on improving donation and transplantation across the country and promote donation in multicultural communities across the board. And the reason behind that is really that amongst the 100,000 plus patients waiting for organ transplant right now, over 60% are actually multicultural patients. As you see here in this diagram, 28% of patients on the waiting list are African American or Black, 21% are Hispanics, about 9% are Asian Pacific Islander, and another 1% American Indian, Alaskan Native, and 1% multicultural. And what's relevant is that 85% of the waiting list is really patients waiting for kidney transplant primarily. And that's, roughly about 90,000 patients across the country. Now, as a big picture, we have about 500,000 patients or more on dialysis. So that's a small drop in the bucket. Not everybody on dialysis is making it to be on the transplant waiting list. And this is where some of our initiatives that we're working on are geared towards. Next slide, please. And this is where we started this initiative a few years ago, and equity in kidney transplant, really to target the Black and brown patient population to get them to transplant and get them supported. This program really works from different perspectives, primarily talking to the patients, not only as physicians and nurses, but also using a health and wellness navigator who is bilingual, speaks Spanish and English, and will help the patient, as we've seen in a lot of efforts in the multicultural clinics, where to target patients, these patients need support and need somebody to walk them through the system and help them through the system, and also figure out what their needs are and connect and communicate that to the team caring for them. The team caring for them is also bilingual. Dr. Cohen has been supporting us, as you see his picture here on the right. We're starting virtual group visits, having multiple patients at the same time, talking to each other, exchanging their own problems and how they're caring for it, and getting support from the physician in these group visits. And those are both available in English and Spanish as well. We're also doing community outreach with local dialysis centers. Some of you on the waiting list in your dialysis units, you're going to see our team reaching out and coming and talking to patients at each dialysis center, because a lot of our patients on dialysis are spending a lot of days and a lot of time on dialysis, and they're there, and that's where we want to reach them where they are. So we're providing additional resources to support everybody through the process and to get people through this process. Next slide. And obviously the process for kidney transplant is detailed and goes through from the patient being started and referred to being evaluated. Then we got to decide if transplant is the right option for this patient, or how can we make it a better option for these patients. And that's when patient starts getting on the waiting list and get waitlisted. After a few years, or if they have a live donor, we get them through the readiness process. And that's where we go through in detail through all their needs and make sure that they're ready for transplant until they get an organ and they get a transplant. And usually every patient that we expect them to get a transplant within the next 6 to 12 months, we get them through the readiness process. We have a couple QR codes in here for patients to scan, either if they want to get a referral from their physician, or if they want to request an appointment directly, and you can use them in here. So we're focusing in this project and in this initiative on every part of the transplant process to help patients through it and help them to get to the goal of getting their transplant and getting off dialysis. Next slide. Now, we've been doing very well, and obviously we're the largest center in New England. We have a multi-organ transplant center. We're the only center in New England that performs all type of organ transplant. We have a growing waiting list, more than 1,300 patients. 10 years ago, we had about 300. Right now, we have more than 1,300. And what we pride ourselves in is that we have more than 35% of our patients pre-dialysis. These are patients that have not started dialysis yet, but have kidney disease and are expected to need a transplant. And we got them on the waiting list initiating this. Across the country, that number is closer to 24%. So we're doing significantly better here at MGH. And in addition to that, we have excellent outcomes post-kidney transplant. Our outcomes meet or exceed national benchmarks. As you see in the next slide.
Oh, sorry, Nahal, I did want to ask a question. Why is it important for patients to be referred to transplantation pre-dialysis?
Excellent point. And pre-dialysis referral, number one, gets the patient started gaining waiting time on the waiting list. And when the waiting time gets up to 6 or 7 years, if 2 or 3 of these years are pre-dialysis, that's make it easier and makes their outcome better. Patients do better when they get a transplant with less time on dialysis. Even better if they get a transplant with 0 time on dialysis. And that's where patients usually get a transplant from a living donor before they start dialysis. And the advantage of getting referred early and get on the waiting list before they initiate dialysis is they'll have time to look through friends, family members, others who are interested in helping them. And that process obviously takes time to make sure that their potential donors come to us and we evaluate them and we get them through the process to get them to get a transplant. So that's an important and relevant point for patients. And the earlier they get on that process, the more time they have before they start dialysis. Thank you for bringing that up, Stacy. So these are our outcomes. The Scientific Registry of Transplant Recipients, or SRTR, contracts with the federal government and publishes data every 6 months, so twice a year. These are our data from January 2022. Our July data is fairly similar to this. Some of it is better, some of it is a little bit lower, but we still do better on 1 and 3 year survival on the left compared to in the US as a whole. On graft survival, that's the percent of kidneys functioning. So we look at percent of kidneys functioning, and you see at 1 year, it's 97%. At 3 years, it's about 94%, and still better than across the country. Now, this is the patient alive and their kidney working. On the right is the patient alive with or without kidney function. And you see the percent of patients alive after 1 year and 3 years of kidney transplant at MGH are still better than the US as a whole. Next slide. Now, as part of our process, we expedite the listing process, so we get patients listed quickly. And that's a big, important piece for the pre-dialysis referrals as well, because that's when the patient starts accruing waiting time. Patients who are already on dialysis will automatically get their start date is their dialysis start date on the waiting list. So on the waiting list start date is equal to their dialysis start date. And that makes it essentially equal across the board, that people who have been referred, a few years after kidney transplant are still given an opportunity to get, a few years after dialysis are given an opportunity to get that dialysis time added to their waiting time. We are a high volume center. Last year, we did 165 kidney transplant, the most in New England, and we continue to do more. Now, when we have a large waiting list, that gives us the opportunity to help more and more patients. But one of the SRTR metrics is also what percent of your list is getting a transplant. And obviously, as we grow our waiting list, it becomes a smaller number, 165 out of 1,300. And that's one of the numbers that we're working on increasing and improving. We have a dedicated care team. We have excellent support from separating the pre-transplant, post-transplant, and the inpatient or during the transplant care teams. So those are 3 separate care teams. Now the physicians cross over from one to the other, but the support team from the nursing to the dietitians to everybody else with the pharmacy, they're all supporting teams that are specialized in what they do, and they dedicate their work to take care of the patients in different phases, and they help with that. Another opportunity for patients having come here at MGH is our innovative research. As I was talking about increasing the opportunity for transplant, we have a couple mentioned trials in here that are focused on hepatitis C organs, and we have been using these on a regular basis through this research project where we can help the patient get a transplant quickly and get a transplant, and we cure hepatitis C by giving them treatment for a few weeks after transplant, and they do excellent outcomes. And we're monitoring this on a regular basis. We also have some tolerance projects ongoing, and that is where we are working on getting patients a transplant and stopping all their immunosuppression one day. Now, again, that's a big goal that we have in transplantation, but it takes a lot of effort to get there, and we're working on it. And we have ongoing research opportunities. And all these added together gives the patient a great opportunity when they come here and get referred to us to get access to these treatments that are not necessarily all available everywhere. So I'll stop here, and we're glad to answer any questions you have.
Thank you, Nahel. I think there was one question. Let's see. From Christine, are eGFR levels different for someone who has had a transplant? I'm 24 with a GFR of 31. He has been there for a long time. Yes. So Christine, that's a great question. So if you're a transplanted patient, you got only one kidney, and therefore, you tend to, most of our patients will have a GFR between 30 and 60. That's kind of the average where most of our transplanted patients will rely. As you pointed out, one of the most important aspects about this is that with the kidney function around 30 to 60, it's more than enough to keep you healthy and going. And following these this GFR over time, so the repeat blood test that you may do every 3 or 6 months is one of the most crucial parts about monitoring what's happening kind of over the line. And in addition to that, of course, looking at your urine in terms of protein in the urine is the second thing that we usually do to monitor our patients.
I think the next question is about when to get that additional dose of vaccine. And this is a little tricky to answer because there's actually a lot of disease going on right now. So we would want people to be well protected. But if you recently had a dose of vaccine, say within the past 3, 4, 5 months, and if you've had Evusheld, it might be okay to wait until September, October for the new vaccine. But we do sort of worry that there's a lot of disease out there, and it would be akin to like saying, I'm not going to put my seatbelt on this time. I'm going to drive really carefully for the next month and then just put your seatbelt on in the fall. So I'm a little worried about doing that. I'm seeing many people who actually haven't had a dose of vaccine since like late 2021. So like effectively last year. For those people, I actually would go ahead and get a dose of vaccine now, and then you'll get another one, whatever we end up saying 3 or 4 months later, most likely. But I think it is really important to be up to date on your vaccines. We are seeing much better outcomes overall in people who have COVID, but that's especially in people who've had all the recommended doses of vaccine. So I would be cautious. So if it was a recent vaccine, relatively recent, you can probably wait. But if it's been a long time since your last dose of vaccine, you should probably go ahead and get one now, and then get one in towards the end of the year.
Thank you, Camille. And it seems along the same lines, if you compare how transplant patients were doing at the beginning of the pandemic and now after getting the vaccines, are we seeing a much improvement in terms of how they're dealing with the infection and recovering?
Yeah, so much better. Don't all of us think that they're so much better? We have so many fewer really sick transplant patients. And certainly between vaccine, Evusheld, and then early diagnosis and early treatment, we're doing so much better these days. So that's a real relief to all of us. I think you should still be careful, but things are much better, and just know about early testing and early treatment. Somebody was relatedly asking in the chat, if you had a booster within the past month or two, can you get another one? There's going to be a recommendation for an interval. We don't actually want the vaccines too close together. So there will be some recommendation for maybe the vaccines to be 3 or 4 months apart. I'm not quite sure what it will end up being at this time.
Dr. Elias, can you comment on about things that can eliminate a live donor from donating, such as age?
Thanks, Leo. I was about to take that question. Good. Yes. So the big thing about living donation, when we're talking about a live donor, these are folks that essentially do not need the operation. They're going through it to help somebody else. So it's very important for us to evaluate them and make sure that their risks are extremely, extremely small going through the donation process. So age specifically, we look at donors up to 75 or sometimes a little bit older, but kidney function, as Leo mentioned earlier, does decrease with age. So an older donor donating to somebody who's young may not be the best opportunity, but we can address these things and discuss it with each potential donor specifically. But the more relevant point is that a potential donor has to be healthy enough to tolerate the operation and tolerate living the rest of their life with one kidney. So they cannot, for example, have any significant risk of kidney disease. And, diabetics, for example, cannot donate, except in specific, very, very strict circumstances. Obviously, people who have any significant illness, we always bring it up with Camille. If somebody has an infection or something like that, we've had to delay, for example, transplants because a donor had COVID at some point. We don't want them to donate when they have COVID. First, for their sake, to go through an operation. It's essentially an elective operation, and it's to help somebody else. So we have to be extremely careful. And that's why, unfortunately, only about 15 to 20% of people who reach out to us and say they want to donate a kidney end up becoming and qualifying to donate a kidney. So it is a small percent, but they have to go through the process. They have to we have a questionnaire that gets them through it first, and then we evaluate them in person and do some additional testing to make sure that they're suitable to donate.
And Dr. Elias, can you comment also on the difference of waiting time for a deceased donor kidney depending on your blood group?
So different blood types, obviously the type O blood type is the most common blood type in the US. It is the most common for donors, but it is the most common for recipients as well, which makes the waiting list on the O blood type the longest. That makes it relatively longer. Now, blood type B seems to be a little bit longer of a waiting time, primarily because there's more recipients waiting for blood type B compared to the number of donors. But blood type O is a close second, and it's roughly around 6 to 7 years. Occasionally, some patients are sensitized. This is where they have antibodies, either because of a prior transplant or because of blood transfusion. Also, women could become sensitized from multiple pregnancies or complicated pregnancies. These being sensitized and have antibodies makes it a little bit harder to find a match for them. And that's where some patients end up waiting longer. Now, the system factors in those things. So, for example, the sensitized patients get additional points on the waiting list sometimes, and that helps them, get more chances to find the donor, especially really tough and really highly sensitized patient. And this sensitization, we measure it by percent. And what it's looking at is really what percent of donors within the past couple of years are suitable. So if somebody is 50 or 70% sensitized, for example, that means only 30% of the donors are suitable for them. So that person gets extra points on the waiting list. But as I tell patients, it's not a great way to get extra points because it makes it harder to find them options sometimes.
And I'll put a plug into our living donor team. So we have these webinars that happen on a monthly basis called Live Donor Champions, which contains a lot of useful information for patients that are in the waiting list in terms of how to get out and potentially, reach out to friends and their networks in order to identify potential living donors. We underestimate how good people are. I have one story to kind of tell that just appeared in the media. There was a transplant physician that just donated a kidney to his patient, and this was such an amazing, I think, act. And we in the profession that we are in transplantation, we do see how many of these people kind of move forward and offer to donate kidneys to their friends, family, and so forth. So having the tools and having help from our team in order to be able to reach out to your network to potentially find a potential living donor, it can play a huge advantage, in particular with patients that have a long waiting time going forward because of their blood groups. Because even if they find a patient donor that may not be their exact match, we have ways which we call the kidney pair exchange program, which is a national program that allows patients that are not compatible to exchange kidneys of equal quality. So this basically allows patients to, once they have a living donor that's approved, to participate in this exchange and allow them to get off dialysis as soon as possible and get a transplant. So we do about 35 to 40 of these transplants a year, and it's a major advantage for our patients to be able to have a national pool of potential donors and exchange kidneys so that they can come off dialysis.
Thank you, Leo. I see another question here asking how long is the process for a living donor?
So I can take that. Living donor evaluation is different, as I mentioned. There are, depending on how healthy the person is, and sometimes it's very quick if the patient has a significant risk that we do not think they should donate. If somebody has no significant medical history and they've been checked out and they've been seen by their physician on a regular basis, they tend to be a little bit quicker. But again, it depends on the patient. It depends, and I've seen patients, as I said, take a few days to take in a few weeks to take in a few months. But it's tough to standardize it across the board. It depends how healthy and how well followed the person is. We've seen people come in to want to donate a kidney that have never seen a doctor before. Now, they may be extremely healthy, but they need to be checked out, and we need to make sure that they have very little risk of themselves having trouble when they donate a kidney, to any very little risk to the recipient of their kidney to have trouble when they get their kidney. And this is where we have to put them through an evaluation process and make sure everything is well. And that starts with the questionnaire. Then the physician sees them. One of the nephrologists, transplant nephrologists on our team will see them, evaluate them. And then they get a CAT scan where we evaluate the anatomy. What does the kidney look like? How many arteries, how many veins? How complicated is it to take out the kidney on this person? Because as I said, we want to make sure that risk is low from the process of donating the kidney and the operation to their remainder of their life, where they're going to live the remainder of their life with one kidney.
So in summary, it's a long process in the sense that there are multiple steps. Depending on the donor, some people move through the process much quicker than others. And of course, this comes to, having the time available to do some of it and so forth. And also some of the maybe abnormalities or things that abnormal and tested people do that may require additional testing. But it's usually a higher bar in order to donate a kidney, because of course the safety of the donor is the #1 priority. And I'll just add that there's sometimes frustrations on the patient that's potentially waiting for that donor to know what's going on. And the way transplant works is that there is a confidentiality kind of wall between the recipient and the donor. So if we're representing the patient that's awaiting a kidney transplant, we do not participate on the donor assessment. So it's a completely kind of separate team. And this is done on purpose, just so that there's no pressure for the living donor to donate, and also to make sure that, whatever decision is made on the donor side, that their risk and benefit is taken to the equation. And so that can sometimes create frustration on patients that are waiting and thinking that donors are available and MGH is not providing enough information. This does not happen only in our hospital. This is just, how overall we have to follow certain protocols, and unfortunately we cannot provide direct information about the donor, but the donor can communicate with the potential recipient awaiting a transplant and tell them what's going on. And of course we try to at least give some updates under what's agreed on to keep the confidentiality straight. Stacy,
There
oh, go ahead, Camille.
I was just going to say there are a lot of questions about Evusheld, and we understand that the Evusheld rollout has been challenging. That's been a national issue. I personally have talked with the CDC about this many, many times. And so we hope to be able to give some of you Evusheld in transplant clinic. The White House has really opened things up so that lots of different people can order Evusheld now. I'm not quite sure what that means for each and every one of you and where you go for healthcare and all of that, but there are some really great programs in the state of Massachusetts. I personally send a lot of people to the state of Massachusetts sites in Plymouth or Holyoke or wherever near where the patient lives. And then if you're not in the state of Massachusetts, actually find good availability in Maine and New Hampshire and some other places. So we hope that we can give it to at least some of you and in transplant clinic, although as you know, our transplant clinic is big, and luckily with these great outcomes that have been described and this robust transplant population, we're mostly doing transplant care. And so it's hard to do a huge Evusheld rollout, and we do apologize for that. It's kind of the reality of our success. But so I'd encourage you to look elsewhere, maybe speak to your primary care doctor, try things on the internet. But there are a lot of places that you could get either a first dose or a second dose of Evusheld. I put a map into the chat. The federal government has actually made this amazing map. My brother-in-law in Ohio used it to find his dose of Evusheld. He looked at the map and he made a bunch of phone calls and he found his dose of Evusheld in April. So especially if you live far away, there might be a site much closer to you that you could potentially access.
And everyone, I will be sharing the slide deck, including those links and resources that Dr. Cotton has mentioned at the end of this webinar. So there is another question that popped up, Dr. Cotton. What types of protections do you recommend for preventing monkeypox?
Laura, that's a great question. So we would, for people that have 2 or more sexual partners within the past 2 weeks, we would recommend the use of monkeypox vaccine, again, the Jynneos one, and that is available through a variety of different sites throughout Massachusetts and elsewhere. Sort of, again, depends where you live, and we certainly have it at Mass General. We've done a huge number. I don't know what, I think we're up to a few thousand doses at Mass General and in infectious disease clinic. And then besides vaccine, so at this point, the transmission is largely due to sexual or other very intimate contact. If you are concerned that somebody you know might have it, we would recommend like avoiding direct contact. Unlike COVID, I say for COVID, you get COVID from breathing other people's air. So I always say, just don't breathe their air, like move away from them, wear a mask, 6 feet apart, all of that. COVID, monkeypox is more direct contact. So if somebody has a rash, avoid touching the rash, avoid direct contact. If you are having, in addition to vaccines, if you are having multiple sexual partners, or if your sexual partner is having multiple sexual partners, we would recommend considering things like condoms and other safer sex techniques, although that may not be sufficient because it could, monkeypox could be in like the oral or genital region that might not be covered. Yeah, hopefully that was clear enough. If you have further questions, right now we are not worried about monkeypox on a large scale, and I hope that you may find it comforting that we are not vaccinating healthcare workers who are seeing monkeypox patients. So I hope that that's helpful for you to know that we're not so worried. We're not worried about getting it at work because we're all wearing masks, and then we're wearing gloves and things. So we're careful. We call that universal precautions. So we're not so worried about it on a large scale at this point. Yeah, and if you have further questions, you might want to read the CDC website. And I hope that answers that question.
That was great. Thank you, Camille. I don't see any further questions. Stacy, do you want to comment on any closing remarks? And we really appreciate, again, Dr. Elias, Dr. Cotton, and their expertise here. And Stacy, of course, that was able to put all this together. So thank you so much, Stacy.
Well, thank you for hosting this and helping us answer a lot of these questions. I know a lot of patients were anxious, and having the opportunity to ask you these questions is really great. I will say that to second what Dr. Riella mentioned, the How to Become a Donation Champion program is a great program for patients who are considering transplantation, who are on the wait list, to get your transplant sooner. And I'm happy to share information about that program as well. It really does equip you with the knowledge and the tools to really get your story out there. It's not necessarily about asking, more so about getting raising awareness for your situation, your need for a kidney. And a lot of times someone may step forward that you wouldn't have thought would have stepped forward. Your network is a lot larger than you perceive it to be. So we'll be sharing some information with you all at the tail end of this event, and we hope to see you next time. Oh, we have some more questions coming in, actually. Are there any activities ongoing to move to opt-out donation program as in Norway? And looks like Dr. Elias is answering that.
Yeah, unfortunately not. I think it's something that's difficult to implement in the US, and currently we're in an opt-in system that, at least for the time being, that's where it is. And I don't believe, well, a lot of people bring it up like you do. Thank you for bringing it up. But unfortunately, across the country, that's not something that's going to be easy to implement and change. And I don't think it will be changing in the near future in the US.
All right, well, thank you again. Maybe we should wait a little bit as these questions keep popping up. Is it okay to get one second Evusheld treatment a few weeks or a month before the next new combination COVID booster?
Sure, that's a great question. We think that you can get Evusheld any time, just not two weeks after a dose of vaccine. And we don't even know that the 2 weeks after the dose of vaccine is so important medically, but it's the way the emergency use authorization was written. So we're just trying to follow the rules, and the rules say that you should not get Evusheld for 2 weeks after a vaccine, but we're not really worried medically or immunologically. In other words, we don't think the immune response has changed. It's wonderful to work at Mass General. I had that question myself about the impact of Evusheld in vaccines. So I went and I asked some of the other faculty who are internationally famous immunologists, and they said not to worry about it. So we are not worried about that. So just don't do Evusheld for 2 weeks after vaccine, because those are the rules. But if it happens, I really don't think anything bad's going to happen to you. So hope that helps.
And then another question about monkeypox. Is it viable in hard surfaces like books?
Yes, it does. Well, so we think about monkeypox being having a long life on hard surfaces like countertops or things that don't absorb. This specifically says books, and I'm not too worried about books. I think it would be very hard to get monkeypox from a book. Like if you're worried about the library, or if you're worried, I don't know, if you're worried about the library, I recommend the app called Libby, which is the electronic app, because I walk around with books on my phone all the time. And then I could get a computer virus, but can't catch anything from my phone app. Yeah, I'm not too worried. We have not seen significant community transmission of monkeypox. And again, we actually have monkeypox in the hospital setting, and we're doing good cleaning, but we're not like doing anything too extreme, and we're not seeing transmission from surfaces or any of that. So I wouldn't worry too much. I have a healthy caution, but I wouldn't worry too much at this point.
All right. And then we have another question. If you get a transplant out of state, can MGH follow the patient thereafter post-transplant?
So I can answer that. So within the first few weeks and months, there's a lot of care that our transplant patients will need, and very kind of close follow-up. So in general, you know, on that early period, a patient, whatever they got transplanted, they should follow with their primary team. We do get patients that have been transplanted elsewhere that move to Boston, and we're happy to assess and evaluate and continue to follow them in our institution. However, that early follow-up and whoever did the surgery and provided the care, it's very important to be done locally, just because there's a lot of fragmentation in care that can affect ultimately, you know, the outcome, the results of the kidney transplant. And I see Richard Smith had an amazing question that Stacey may be answer live. If those that got a transplant already could share the experiences with others in the pre-transplant, and I think this is a great opportunity. Stacey?
Yes, absolutely. You can actually contact me, and I can add my contact information in chat box. And also you'll have it whenever I send out the email. We love to hear your stories. We love to be able to share your stories. And even patients who are on the wait list awaiting a transplant, they love to hear your stories too. So we absolutely love this. And I will connect with you after this webinar. And
I think that's a great topic. I have been asked by the CDC and others to interact with patients, and we take patient privacy so seriously. We would never ever release any personal information. But for people who might be interested in being a transplant spokesperson or talk about Evusheld or things like that, it actually really helps shape national policy at times. So there's that. So if you're willing to be a spokesperson, Stacey could keep a good list for us. And I will say that I've had some beautiful stories. I had some patients who needed a liver transplant, and they were way up in Maine on the Canadian border. And with permission, I was allowed to pair them. So they were buddies, so they could kind of walk each other. One had had a transplant and one needed a liver transplant, and they were able to like buddy up and kind of share the process. And it made the process so much better. And it was a really nice experience. So if you have a little bit of time, I think it could be really rewarding. And certainly the person going through the transplant process really finds that quite useful. You can give them all the tips you've accumulated over time.
all right, well, on that note, I think that was the last question, and we are coming up on an hour. Again, thank you all for joining, for asking such great questions, and thank you to the experts for sharing your expertise and really being available to answer these questions, right? I know there's a lot of confusing information out there, which is some of the feedback that we've received, and these sorts of webinar updates are really well received and appreciated.
Thank you, Stacey, for putting this together.
Thank you, Stacey, and thanks everyone for joining.
Have a good night, all.
Thanks. Bye.